And she has functioned as an advanced practice nurse in psychiatry, continence, wound care, and geriatrics. Currently, she's a field leader for the Masters of Clinical Science Wound Healing program. No, yeah, okay, go ahead. I'll stand. At Western, and she's a wound care project manager of aging. Rehabilitation and geriatric research at the Lawson Healthcare Research Institute, St. Joseph's Healthcare, London. Dr. Campbell co-led the development of the Canadian Best Practice Guidelines for pressure ulcers and has played a role in the development and revision of 4 RNAO Best Practice Guidelines for wound healing. She has also published several articles and book chapters on wound healing. So with that, welcome Dr. Campbell.
And I have to say that Kim LeBlanc's name is here. Kim LeBlanc was supposed to be here today, but she's back at school working on her PhD and called and said, would I come and pinch hit for her? And so I've left her name on this because these are her slides and this is her work. And Kim has done a tremendous amount of work in the area of skin tears, and I know anyone that's reading the literature will see her name. So just as a little background information, today is look at risk factors for skin tears, classifying skin tears according to the ISTAP classification system, and then discuss interventions related to the prevention and management of skin tears. You don't need a copy of these slides because all of this information is on a website, and I'll show you the website as we go along. And so everything is available for download because we want people to actually use this information. Alrighty? What do skin tears look like? And I know working and talking to a group of long-term care experts, you see skin tears every day in your practice. And Kim, I think, really decided to take this on as a mission because people would say to her, oh, it's only a skin tear. Oh, it's only a skin tear. And her work in long-term care said to her, this is not just only a skin tear. We need to be doing a lot more work in this area. And so I know I'm preaching to the converted in this room because you folks get it. Of course, you have to have a definition. So a skin tear is a wound caused by shear friction and/or blunt force resulting in separation of the skin layers. I'm actually sometimes get called to say, is this wound a skin tear or is this wound a pressure ulcer? Because pressure ulcers can be caused by shear and friction. But of course, it's a different etiology. And again, I know that in this group, you probably understand the difference. But a skin tear can be a partial thickness or a full thickness. So they can be shallow or much deeper. What are the prevalence of skin tears? So there's a poster actually up in the poster section, which is work that was done by Kim and Don Christensen in Ottawa in 2011, and they found a 22% prevalence of skin tears in the long-term care setting that they studied. Carolyn Carville asserted that skin tears are perceived to be common wounds and occur more frequently than pressure ulcers, and I'm wondering if I see a lot of nods from the audience, so you folks likely concur. Carolyn, as well, in Australia, found that in a veterans population, 20% of them had a prevalence of skin tears. In a study of community settings, the prevalence there was 5.5%. And a 1994 study in a long-term care facility in Western Australia demonstrated over 40% prevalence of skin tears. So we know that it is a common problem. Early research estimates that 1.5 million skin tears occur every year in institutionalized adults within the United States. And again, I know I'm preaching to the converted in this room. So there was a consensus document that was published in the Advances of Skin and Wound Care in 2011, and if you go to the website, you'll be able to see this article. I'll go through the consensus statements, and if you want to read more about how these were developed, there was quite an extensive process and an international panel as well as international stakeholders. So intrinsic and extrinsic factors contribute to the occurrence of skin tears, and some of these factors are yet to be determined. Skin tears are most prevalent in the extremes of age, so the very young and the very old. And we have a picture there of a preemie and then of an older person. And my expertise is not with neonates. My expertise is more with care of the elderly. So the physiological changes related to the aging process affect the skin ability to resist shear, friction, and blunt force, as many of you are well aware of. Physiological characteristics of the neonate or infant skin may affect the skin ability to resist shear, friction, and blunt force as well. Individuals with impaired activity, mobility, sensation, or cognition have increased risk of shear friction and/or blunt force injury related to the need for increased assistance. And we know that, I'm going to talk about this in a later slide, that many of these skin tears occur during care being delivered, again, as you folks are probably well aware of. This was a survey that was done with an international group of clinicians, and it looked at the clinicians' perception of what were the main causes of skin tears. So blunt trauma was at the top there, while performing activities of daily living, while doing dressings. These were more treatment related, were probably second. Third were falls and equipment injuries related to wheelchairs, side rails, and any sort of equipment. Last, during patient transfers with friction and shear. I'm sure this is not surprising to you folks. So you need to do a comprehensive assessment of risk factors for skin cares, and it needs to be conducted for all individuals within your environment, and you need to look at the contextual factors within the environment. But with anything, it's not just about assessment. You then have to do something about those risk factors. A bugaboo of mine is people assessing and then not doing anything about their assessment. But obviously the first step is that comprehensive assessment of the risk factors, not only in the individual but in the environment. A collaborative, multidisciplinary or interdisciplinary approach, once you've identified those risk factors, to look at prevention as well as management of those skin tears. Skin tears are to be assessed and documented on a regular basis according to your healthcare setting practices and policies. Evidence-based wound care principles should guide treatment of skin tears. In a few slides, I'm going to go through some of the recommendations for those. Patients, caregivers, and healthcare providers should be educated regarding the prevention and management of skin tears. And not all skin tears are preventable, just so people know that. I know the panel, we had much discussion about this and felt that many can be prevented, but not all are 100% preventable. You have to have something about further research, don't you, on all these guidelines? So further research is needed to expand scientific knowledge to determine best practice for skin care prediction, prevention, assessment, treatment, and documentation. There is no skin tear risk assessment tool like there is the Braden scale for pressure ulcers, for example, and we do need more research in that area. So introducing a validated skin tear classification system, and I had the fortune and honor of being part of both the consensus process and part of the classification system. The previous classification systems that we had looked at from around the world confusing, and there were too many different, if you have this, then you have that, and there was a lot of, some of it was subjective, and so felt that needed to be all overhauled. Again, this is on the website if you want to get it. So essentially a type 1 is a skin tear, but the skin flap can be repositioned, and so it can either be a linear or flap tear that can be repositioned to cover basically the whole wound bed. A type 2 is a partial flap loss. So it's basically the flap is all there, the flap is partially gone, or the flap is totally gone. Very simple, I think. I can keep three steps in my mind. I don't have to have something in front of me kind of walking me through kind of all the steps, and I think fairly straightforward. So there's just an example of a type 1. Type 2, fairly straightforward. Type 1 was totally approximated. There's a partial flap loss here. There's a full flap loss. So to treat skin tears, nurses must understand who's at risk for developing skin tears. Then you need to know how to prevent these wounds from occurring. And lastly, you need to know how to manage these challenging wounds should they occur. So ISTAP has developed a toolkit, and again, that's on the website. The toolkit includes the following. There's a risk assessment pathway. There's quite a long list of all the risk factors, and so there is a pathway. There's a quick reference guide for the ISTAP risk reduction program and rationale. There's a skin tear decision algorithm. There's a pathway to assessment and treatment of skin tears. There's the ISTAP classification system, a prevalence study data collection sheet if you want to identify what the prevalence is in your organization, and then there's a product selection guide. This is what the toolkit looks like. So obviously you have a skin tear that's occurred. You're going to assess, you're going to control the bleeding, obviously provide any first aid that needs to be done. You're going to cleanse that area. You're going to approximate the wound edges, and then you're going to classify based on type 1, type 2, type 3. So completely closed, partial flap loss, full flap loss. And you're going to measure and document. And then you're going to look at the goals of treatment. So obviously treat the cause. What were the causative factors for these skin tears? And you're going to implement a prevention protocol. As you all know, when one skin tear occurs, others can occur as well. So although we're in treatment mode for that skin tear, you have to go in prevention mode for all the other parts of the body. We're going to be using moist wound healing. We're going to avoid trauma, going to protect the peri-wound skin, going to manage exudate, avoid infection, and manage pain. This is really no different than any wound care protocol when you think about the wound bed preparation paradigm. And in the toolkit, they do discuss treatment options based on the type of skin tear that you have. So this is the pathway to assessment. So in terms of treating the cause, looking at their general health, their cognitive status, their sensory status, visual, auditory problems, nutrition, any chronic or critical diseases, polypharmacy, history of falls, impaired mobility, activities of daily living, and then looking at the actual skin, the age of the skin, the fragility of the skin, whether there's any mechanical trauma from equipment, and looking whether or not there's been previous skin tears. In terms of the local wound care, then we need to think about atraumatic dressing removal. We want to cleanse the wound. We want to control bleeding, approximate the wound edge, and then assess and classify according to that classification system. Deal with any patient-centered concerns, so pain, education, there may be other patient-centered concerns that you have to deal with. And then in terms of going down to the next level, this is just the wound bed preparation paradigm. And this has been adapted from Dr. Gary Sybil's original article, looking at debridement of non-viable tissue, avoiding sutures or staples, dealing with any infection or chronic inflammation, so topical antimicrobials for local infection, systemic antibiotics for deep infection, and to consider tetanus immunization. Obviously, that's a big and very important point here. And then looking at the moisture balance in terms of the dressing selection. So You want to keep the moisture in the wound from the skin tear, like the moisture in your eye, not too wet, not too dry. But all the while considering non-adherent or low-tack dressings so that you're not causing more skin tears with dressing removal. And then looking at whether or not this skin tear is healing, whether you have an advancing edge to the wound. You need to be constantly reevaluating to see if the wound is healing and to consider more active therapy if the wound is not responding to that treatment protocol. Don't forget the tetanus shot. I've already said that, and Kim's got the references here. And so that the tetanus shot should be given before wound debridement because the exotoxin can be released during wound manipulation. So that's an important point to consider. And it should be given to all individuals who have had an interruption of skin tears by a non-surgical mechanism. So that's an important, you may think, okay, that bedside rail was clean, but if it's not a surgical mechanism, which that wouldn't be, then they need to have their tetanus shot. And that's a reference from the American College of Emergency Physicians. This is the all-important website, skintear.org. So very straightforward, very simple to remember, and you need to go there and use it. So just in conclusion, the International Skin Tear panel members were in agreement that skin tears represent a specific and challenging type of wound. These are not just skin tears. These are very important wounds that can be prevented and should be prevented and need appropriate prevention as well as management and treatment. Skin tears affect all ages and are a common problem, as I've discussed with you, in healthcare settings. Prevention should be the primary focus, knowing that we can't prevent 100% of skin tears. Literature pertaining to the prevention and treatment of these wounds is limited, and further research is needed to determine the prevalence and incidence of skin tears across the healthcare settings, identify and validate an internationally accepted skin tear classification system, and validate a risk scale or predictive document such as we have the Braden for pressure ulcers. And lastly, best practice prevention and treatment guidelines are needed to assist healthcare professionals in managing skin tears and identifying those at risk for these wounds. The references, and I will stop there.
So thank you, Karen. So our third presenters, which are really our second presenters, are going to speak about profiling and case costing wounds in long-term care